You could look at bone marrow as your target organ and try and keep the dose there to less than 2 gray. Or you could be using it as a neoadjuvant treatment to render a patient potentially suitable for surgery, and perhaps in the future we might have agents for pancreatic cancer that might target that so that people can go on to successful surgery where now they can't. But overall, whatever you choose here, our aim should be to improve overall survival. So I'm going to draw on a couple of papers that have been published in the last decade looking at the use of clinical radiation dosimetry calculations. The first one was mostly written by medics asking, come on physicists, when are you going to get it together? And the other is the 7-year later response from the physicists is what they're up to. Now, when you think about how we approach treatments, and this has been referred to in the previous session as well, you can start with little or no patient-specific information, such as we do with iodine therapy, have been doing for 50 years or more. It's the one-size-fits-all approach that John Matthew referred to. You could go for a little bit of information, and again with SIR-spheres we often use a BSA formula where we perhaps erroneously think that the liver size is related to the BSA. It's not always applicable in the setting of primary or metastatic liver cancer, but you somehow modify the dose based upon the patient's body habitus. And at the other end of the spectrum, as I say, what the radiation oncologists are doing today, time-consuming, precise definitions, dose painting, trying to get maximal doses to tumour, minimising the splash dose and normal tissues, and even providing boost doses, often based on the functional images, as you can see here from FET PET scanning combined with the MRs. So it's clear that when you go from the less specific to the more specific, you need a lot more information, you need a lot more time, that's certainly for sure. Today, of course, the lutate treatments, as we've been hearing, are very much standardised. Like Jean Matthew, we are locked into a predefined protocol that doesn't allow us any ability to vary the dose given, so therefore standard doses in our department. We are looking, however, at things like trying to get the SIR-spheres moved from minimal information to something far more precise, and looking at things like imageable spheres and pre-treatment planning. The obvious advantage and attraction of the standardised dosing regime is that it's easy to implement, but it neglects a lot of factors, and if you sit in your cancer board meetings or your MDTs, you hear a lot about this. It's not just the size of the patient, it's their tumour burden that matters, it's the tumour uptake, it's the rate of progression, the trajectory that we're seeing in this patient as we've followed them in their progression path. It's also recognising the intralesional heterogeneity, and listening to Ben Lawrence's talk this morning, there's clearly so many other genetic factors that you could throw into this. So the two patients I'm showing here are a 46 kilogram lady and a 111 kilogram male, both for lutate therapy, both given exactly the same amounts of treatment. There's not a whole lot of sense behind that. So if I look at the first paper, these were the goals that were put out for individualised patient dosimetry, to get an individual minimum effective and maximum tolerated absorbed dose. And I think importantly the second one, to try and establish a dose-response relationship based on particular pathologies with certain treatments, using the pre-therapy dosimetry to do that. To provide some objective comparison between dose-response relationships from different radionuclide therapies. We're hearing about lutetium, copper, yttrium-90 and so on, either between different patients or between different radiopharmaceuticals, and as well to perform comparisons with the results from external beam therapy. Now, I think we're all of the opinion that we shouldn't be applying external beam dose limits to kidneys, livers and other organs, but we still have to define what our own limits are. And so we need to work that out. And we basically want to increase the knowledge of the clinical radiobiology. And when you look at the literature, a lot of this tailed off for radionuclide therapy in the mid-90s, having been very active from the 60s and 70s, and it's starting to be readdressed again. When we talk about dose response, this is the sort of thing we're looking at. The curve on the left from Stefan Warand and his group showing a dose response for PRRT using yttrium-90, where the doses are calculated on the bottom for different lesions, and this is the size reduction by RECIST criteria. And some CERT-related information from Patrick Flamen and Bruno van der Linden in Brussels, where they use predictive dosimetry from MAA pre-treatment planning for CERT therapy to look at then change in the total lesion glycolysis with FDG. And then we did a similar study, but As you heard, you can image yttrium-90 quantitatively on the PET camera. So we actually measured the doses on the PET camera and related that to the same parameter, the change in TLG. And perhaps not surprisingly, got very similar results to the Brussels group. So these are the sorts of things we're trying to establish. Now, what is the evidence for the use of individualised dosimetry? And the previous chairman raised a question about this, and I think it's a great question. So in the paper that I referred to from 2014, they looked under this search mesh, which you can see is fairly sensible, some sort of therapy and like some sort of response, including a term related to Grail, but not related to external beam radiotherapy. 92 papers, predominantly phase 1 and 2, as you can see, but 34 were just stamp collecting exercises, basically, with no defined protocol as such. Dosimetry was reported in the majority of the papers, nearly 80 out of the 92. Overall survival was reported in a substantially lesser number, only 22 of 79. Quality of life, which is almost essential for publishing in the clinical oncology literature, was reported in 1 of 79 papers. So something we do need to pay attention to, and that has been highlighted to us throughout today as well. The pathologies for which this has been published as well, obviously thyroid cancer, both malignant and benign thyroid disease, neuroblastomas with MIBG, NETs of course, lymphoma, going back to the Zevalin and rituximab story, for SIRT in liver cancer, for more recently in bone palliation with samarium and other agents for that, and a few others with monoclonal antibodies using yttrium-90 and lutetium-177. So that's where it's been attempted to be applied to patients. Now, again, another decision, and I think there's been a bit of discussion about this in the last session, is if you're going to do personalised dosimetry, how do you do it? And I'd like to suggest there's actually 3 different ways you can go about it. You can use a tracer dose approach, so you use the same radionuclide for the planning and for the therapy. We sort of do that anyway with I-131, although we don't plan before thyroid ablation, but certainly in surveillance scanning we're essentially doing that. With rituximab, which I have no experience with, I'm told that you need to do a tracer dose to establish the amount of bone marrow dose, which is the organ at risk in this example, and you could imagine it doing with lutetium-177 PRRT. But the very low photon flux from gamma flux from lutetium-177, I think wouldn't make for the best data. So that's one way of doing it, or, as we're talking about at this meeting in particular, using a suitable theranostic pair. I-124 and I-131 has been used extensively at Memorial Sloan Kettering for planning thyroid treatment. Every thyroid patient gets a planning scan with iodine-124 and PET. Copper-64, copper-67 is a particularly attractive example because it's the same element being used in both cases, and so there's no sense that the molecule might be slightly distorted and therefore the affinity might change because of that. One that I'd like to highlight to you, which I think is of great interest, gallium-67 and lutetium-177. I heard gallium-67 referred to this morning as an old nuclear medicine radionuclide. We still do lots of gallium scans for infection in our hospital because our infectious diseases department really like it. There's also yttrium-86, which is a PET radionuclide that you can use with yttrium-90. The third option you've got is to just use your initial treatment dose to individualise all the subsequent treatments. And this is particularly attractive because you don't have to do any sort of planning scan, and the planning scans can be very time-consuming and difficult. So you'd imagine doing this for your dotatates and your PSMAs, for example. Now, when I look at the radionuclides that I don't think are suitable for planning, if you're trying to get a time-integrated curve of the uptake and retention or washout, the first 3, gallium-68, fluorine-18 and technetium, are clearly the workhorse radionuclides of nuclear medicine, and I'm saying they're not suitable. I don't really think one time point at 60 minutes after injection is going to be sufficient to capture the variability in biology that we see between patients. I also put yttrium-90 up there, although I thought the paper using yttrium-90 DOTATOC we just saw was very interesting in the ability to be able to get an image from a systemic injection of yttrium-90. I think you can get a good PET image from yttrium-90 when you've got 1 to 2 gigabecquerels contained in a region of the body such as the liver, but it's very challenging with systemic injection. So for that reason, in spite of the longer half-life, I've put down that that's not really a suitable way to plan therapy. What do I think would be suitable? Copper-64, clearly. We've heard a bit about that today because of the longer half-life. Gallium-67, I'll come back to that. Yttrium-86, indium-111 has been mentioned a few times today, can be used for both planning and for treatment. And the iodines, 124, 123, 131, with their longer half-lives, all lend themselves to the ability to be able to use for planning. Gallium-67, I think, might need a bit of revision. We've done some work recently looking at imaging the upper two peaks that we conventionally image with in nuclear medicine, neglecting the lower one at 93 keV, and you still can get some very excellent image quality. And you can also do it simultaneously with technetium on board. So the gamma camera's energy resolution has the ability to separate those. So I think that's also that you can substitute gallium-67 where you might use gallium-68, say on a dotatate molecule. I think could make it potentially attractive if you wanted to use the tracer dose approach to planning your therapy. So something perhaps to think about going forward. And we've certainly made some gallium-67 dotatate in our institution. How do you calculate this dosimetry once you've chosen what you're going to do? Well, you do need quantitative imaging, ideally in 3D, ideally with CT. If it's 2D, like most of it has been for the majority of the time we've been doing dosimetry, we're stuck with using planar images and then revert to MERD pamphlet number 16, seen here, which describes how we make those images quantitative as we can, and then obtain time activity curves of percent injected dose. We need somehow to identify the organs, and this is of course the major challenge in planar imaging with the amount of overlap that we have. We need multiple time points determined by the biology, usually over multiple days, and therefore we need that right half-life to match the biology. And it's got to be under the same conditions as for the therapy. So if we're talking about the dotatates, we use radiosensitizers in our institution, 7 days of capecitabine prior to treatment, and then you've got a 3-hour amino acid infusion, which you would need to do in your tracer study as well, therefore complicates it quite a bit. You might want to also think about blood sampling to estimate the dose to the bone marrow. You then go on, you select your organs somehow, displaying the significant uptake on your planning study. You define either VOIs or regions of interest. These days, a lot of good segmentation tools available for 3D work. You then get that percent injected dose in the organs, and usually there's a few assumptions about some organs, such as the bone marrow and the gut, where there's obviously a very large distribution. It's difficult to define. The good news is that there are plenty of software applications coming through that you can use now to do this dosimetry. The Olinda EXM package has been the standard for a long time, accepted by the FDA, based on planar imaging. But there are other packages. There's a company called Doseresponse from France that have got a package for Y90. Philips have got a package adapted from radiation oncology called Stratos. ABX Crow, who I've noticed here on a stand, have got a package called QDose, which does SPECT and planar imaging work. GE have a package, as does the Siemens. So everybody's sort of getting into this now, realising that there will be a need to do this sort of dosimetry calculation. So here's an example from a copper-64 sartate image. You can see that it's very easy to define these regions for lungs, livers, a region in the heart to look at the blood. Just so simple in 3D. It really is very easy. But if you're stuck with these sorts of images, which is what we are at the moment with dotatate, then we're doing blank scans with cobalt sheet sources, transmission scan prior to injection, followed by subsequent emission scans. And we use the transmission and the blank to derive an attenuation correction for the entire body, and then we end up with this quantitative image here. And so here's a comparison of a patient from our department, the gallium dotatate scan showing multiple lesions from a neuroendocrine tumour, primary seen here, multiple lesions in the liver. This is the uptake of the lutetium dotatate immediately at the end of injection with 100% of the activity remaining in the body, and then over 2.5 hours later, roughly 24 hours and 3 days later. And so we've done a lot of work with these data to look at retention, and 2 different individuals shown here, one with a very rapid clearance early on and then a slow component, and this bi-exponential nature is what we see in all of the patients. Here, slower clearance and then slower initial clearance and then the longer part there. It is terribly, terribly reproducible. We derive these data from the whole body planar images, which are quantitative, using the MERD approach, and you can nearly overlie them most of the time. So I think you could use the first treatment to plan the subsequent ones with a fair degree of reliability. You've got to make the SPECT imaging quantitative if you want to use SPECT for that purpose, and so there's been some work done in this area, Peter Mack here, and also with ourselves. And we've been looking at some performance parameters for that, as physicists like to do, and you can see that we can actually get quite good quantitative values for reconstructions in phantoms with lutetium, with sort of therapeutic amounts in the phantom, but we also like to validate these in vivo, and here we're looking at the concentration in the contents of the left ventricle compared to a venous blood sample taken during the SPECT acquisition, and you can see that we can actually get a fairly good agreement pardon me, between those two measures, indicating that even in vivo, in a very non-homogeneous area of attenuation of the body in the thorax, we can still get very good quantification with lutetium-177. We also like to have a standard in the field of view just as a bit of an insurance policy to make sure that nothing's gone systematically wrong. And looking here at 116 imaging sets with treatment where we know the activity inside the phantom, the calibration standard, you can see that we're within 1% accuracy all the time, so most of the time on average. So I think we are able to now use quantitative spec for lutetium-177, and certainly the manufacturers are heading in this direction as well. We've published a number of papers on the use of lutetium and gallium for this, in particular looking at the quantification accuracy and then using that to look at the biodistributions. To do the renal dosimetry, as everyone's been talking about, we follow the same sorts of methods as others. We segment based on the CT scan, relax that regions a little bit, and look at the total counts within that on the SPEC scan. We then plug that into a Linda typically. We've got a number of time points there, and we get the integrated time activity curve, a number of disintegrations, and that comes out for a certain administered dose to give us, in this example, 2.1 Gray to the kidneys. So that's the standard that we've been using. We've also noticed what Joel Matthew was referring to, that it seems that those patients who do get a higher kidney dose calculated from these measurements generally have a lower GFR, and we're now looking at this in a larger series. These are not corrected for organ mass at the moment, and I think it's going to get even tighter when we do that. So it's a message that when you see variability in the doses for different patients, have a look at their renal function, because that might be the clue as to why you're seeing that. And we produce a standard output showing the kidney dose per cycle, the amount administered, and certain retentions. So then we know if we can treat again. Now, where are we heading with all this? What I've told you so far hasn't made your life any easier. Now what I'm going to tell you is actually hopefully going to make your life a bit easier. I want to try and move all this work towards 3D only imaging with a gamma camera. My vision is that the patient for the bone scan will come in, lie on the bed, have a whole body spec CT and walk out the department. And that'll be the end of it. It won't be successive planar scans, spot scans, spec to the lumbar spine, spec to the thoracic spine. Just do it like a PET study. And what we're going to get out of this are quantitative images. So what I'm showing you here is a planar scan, a bone scan, compared with a planar scan derived from reconstructed spec data. And there's not much in it at the moment, and this is very early work that we've started. I think it's only going to get better. So we want to move away from planar imaging altogether for routine scanning, as I mentioned, for the bone scan, but also for all this dosimetry work. Much better if we could have whole body spec CT. We want to replace that planar imaging with whole body spec CT at each time point to derive the biodistribution for the dosimetry, and with the proviso that it's not going to take any extra scanning time than we spend at the moment. But we need to retain the ability to produce both attenuation and non-attenuated planar scans, because we know that's what the FDA and other regulators are used to. So we should be able to derive that from the spec data. So here's some examples. This is the planar scan on a typical patient, anterior-posterior views. These are reprojected. These aren't MIPS. This is actually the whole data set attenuated and forward projected as you would in the imaging process for comparison. And this is a zone thing, the a priori attenuation with a bit of a thresholding issue in this at the moment. What I'm trying to show you, though, is that I think we can get very close to replicating planar imaging if we just do whole body SPECT, should we need to. I think it's just a transition phase that we would go through, and we would move totally to 3D dosimetry. So that's really coming along. So we are now about ready to start to implement quantitative whole body SPECT for dosimetry. Given the limitations that the biology still makes significant demands on the patient, number of time points over a number of days, but we're going to try and make that as easy as possible. We still have the poorer spatial resolution compared with, say, PET, which can cause significant underestimates of the lesion uptake and concentration. So perhaps the smart reconstruction algorithms are going to start to help us to do that, to overcome that and get a better concentration estimate. And we still need a finite time required to create a single whole body time point. But we've set our limits at about 30 minutes. We don't want to take any longer than that for a whole body spec CT, and this is underway now. So in the 2014 paper, the 2007 paper, these issues were listed as the challenges at the moment for doing whole body dosimetry. And you can see there are a number of them. But I think as we look through them now, we're starting to tick off a lot of these, and we can start to do something more realistic with this. So certainly issues of tissue heterogeneity, and the more we learn about the genomics and the heterogeneity there is still not been addressed. How do we detect minimal residual disease and treat it? And what changes are due to the therapy itself. But many of the other issues, I think we have built up in the past decade or so a significant body of knowledge about, and have overcome a lot of the technical issues. So, in conclusion, are we getting any closer to this holy grail of individualised dosimetry? The first message is SPECT imaging is becoming routinely quantitative, and that's going to be a big help. The dosimetry apps are becoming easy to use for a wider range of radionuclides. They're better validated and more widely available. The biodistribution imaging will be capable with quantitative whole body SPECT CT very soon to most of you. It's already available to some of us now. Our knowledge base is expanding rapidly, and there's a growing realisation amongst all of us, I think, that we need to move away from EBRT thresholds and also thinking about it like external beam radiotherapy, thinking more about the biologically effective dose. So what next? Well, for each therapy and each pathology, we need to establish the dose-response relationship. We need better levels of evidence. We've heard this message time and again today. For individual dosing needs to be produced. Otherwise, there's no need. We should just stick with the standard. Standardisation of the dosimetry calculations will be necessary. There's a number of different ways that people are doing it at the moment, and the physicists need to get their act together a little bit and standardise that and harmonise. Multi-centre RCTs will be desirable, if not essential, for wider acceptance. And we need to understand the radiobiology of low-dose irradiation with beta radiation much better than we do today. But I think with that, we're getting much, much closer to achieving this holy grail. Thank you very much.
Thank you very much, Dale, for an excellent overview of this field and what the options are. I have one question for you, or one view into the future. As I see it, if we are very circumscript, only looking at PRRT with lutetium-177, if we look a couple of years ahead and we accept that we need to do individual dosimetry, which is not at all maybe really proven, do you rather think that we would do Q-SPECT on the first dose, or do you think that imaging ligand like copper-labeled somatostatin receptor ligands will, to do the pre-therapy dosimetry, will be the one winning this game?
So if you've got a PET tracer that's got a long enough half-life, then you would do it with PET, I'm sure. But we don't often have that. And also, if you think about CERT planning, you don't do it just to do the dosimetry. In fact, you don't do it to do the dosimetry. You do it to make sure you're not addressing non-target tissues, and also to look at the liver-lung shunt fraction. So if you do that, for those reasons, you then get the dosimetry as well. So it's the motivation for doing it. I tend to think with the PRRT, with lutetium, with amino acid infusions and all the other complications, that I think you just use a standard dose first off. I think that's what we would do anyway. But I do think gallium-67 has got a role here. I really do. I think it's a wonderful long half-life, 78 hours.
The
dosimetry's no, the gallium-67.
Yeah, oh, 67, sorry, yeah.
Instead of gallium-68 in the PRRT environment. I think if people wanted to go down that path, then I think that's possibly a good way to go, because the imaging characteristics are quite good.
Yeah. Thank you. I think we have to move on.
Can I just sneak in one more?
Sure.
While you're there, just in a spirit of debate, I was a bit surprised to see your total exclusion of technetium as a guide to dosimetry, given that the obvious radionuclide you would pair it with therapeutically would be rhenium-188, and the half-life is only 3 times longer than technetium, whereas the half-life of copper-67 is 5 times longer than copper-64. And especially with the improvements in SPECT that you proposed at the end, I would have thought there was an obvious reason to use technetium.
I still think you need, most of these biological processes, you need to image probably beyond 24 hours. So I think that's pushing it a bit. I mean, if you're getting into rhenium and the shorter half-life of the therapy, perhaps that's a unique situation. But I dismissed it on the grounds of the short half-life relative to the biological half-times.
Thank you.
Steve, was there? Yeah.
Dale, on your dosimetry curves over multiple times, and you described it as bi-exponential, but a lot of those later ones look fairly linear, and as one of the earlier speakers today said, it was pretty well fixed from that point, saying that you could measure it just 6 hours or 24 hours. Do you have a comment on that? Do you feel that you need the full out, or do you think you can just pick that first spot and
I think it's the
linear?
early phase that's really important to define, because we see a factor of 2 difference in kidney dosimetry based on the fast component of clearance. The slow component is fairly stable. We've now moved our time points out further to get a better fix on that. It's still around I think it's 58-hour half-life. So possibly you could do that, and certainly not all patients can come back on day 3 or 5, but they're usually happy to come back on day 1. So we've usually got 3 points, so sort of half-hour, 4-hour, 24 hours, and that helps to define that early part. So I think you could probably get away with that, but I think the lesson we've learned from being involved in PRRT therapy for neuroendocrine tumours is that every patient's different, and you don't want to make too many assumptions. Thanks.
Thank you very much.